resident
लंबा
of
सांस लीजिए, छोड़ते जाइए, लेते जाइए, छोड़ते जाइए. Carry on.
sir, patient is a 60-year-old lady, sir, resident of sir Itawa,
नीचे देखिए पैर की तरफ.
so patient presented to us with a chief meter ill-defined lump involving
What size?
sir 3 cross sir approximately sir 4 cross 3 centimeter lump.
Okay, fine.
Sir, involving this sir the right hypochondrium, epigastrium, and slightly extending towards the sir umbilical area, sir. Which
Not lumbar region.
sir, slightly extending towards the umbilicus and right lumbar region also, sir. Sir, which is sir slightly tender on sir palpation, which moves on respiration, and sir finger could not be insinuated between the sir costal margin and the lump, sir. And the sir dullness is continuous with the sir liver, and sir sir, on examination, sir, there is no palpable sir Virchow's note also, and sir, and on no other or solid organ can.
Good morning, friends. We move on to the next case that we had put up for you to reply to, and I must compliment I think a whole lot of you for answering it quite correctly, and although you may not be able to make a diagnosis based on the information that we have provided, I am happy that some more information was sought, and especially by Naveen, also by Rishabh, and the other students asking for more information, Riyan Sharma. Now they are all asking for more information regarding this lady. So she's a 60 years lady that had pain abdomen history of 3 years duration. So it's kind of an old history, but that can be there, and she did not notice any lump for all this time. She noticed a lump only recently, and that lump is for the last 3 to 4 months, and mind you, patient has no history of jaundice, and there is a lump in the abdomen. So the history that we had given provided to you was 60 years lady with history of pain abdomen for the last 3 years that is associated with nausea, loss of appetite, and weight, which can happen to in many inflammatory conditions, also in malignancy. There is no history of jaundice or vomiting. This was important. So there is 3 years history, no history of no jaundice or vomiting. So you know what does this do? It, in a very subtle way, absence of vomiting rules out an upper GI pathology and normal bowel and bladder habits. That kind of rules out of obstruction and bowel pathology and bladder pathology. See, there is a subtle way to get it in the history. Everything cannot be revealed as you want it, but by and large, this is the information that we could provide. Yes, and the examination findings were provided in the video. So you are supposed to make an analysis of whether it's what was spoken as hard lump lying in the right hypochondrium, extending onto the right lumbar region. Naveen was asking if more information can be provided about the liver and its surface. Well, I can add it now. There was a hepatomegaly, and this was a separate lump, and the liver was palpable, but there were no nodules. If the surface is nodular, he is right in asking. You're looking at a metastatic nodule. If the surface is smooth, you're looking at a primary carcinoma if it is hard in consistency. And then there was a lump felt, which is classically lying in the position where you find gallbladder. And remember, gallbladder is not just confined to the right hypochondrium, because its right hypochondrium is a very, very narrow space. If you all recall your initial days in the clinics, that's how we divide our quadrants in the abdomen. That's antisphenic spine here. That's the tip of the ninth costal cartilage. That's umbilicus. And that's a mid-clavicle line which is going straight down on both the sides. So it also will cross the deep inguinal ring here. That's deep inguinal ring. But antisphenic spine is not the point where we take it. We go to the highest point and then we descend down. That's the iliac crest. And this is tubercle. The transtubercular line is taken across. And the other one is the tip of ninth costal cartilage. So it generally would be somewhere in the middle of this line, roughly. And we have the quadrants divided, and you know what they are. If I am now finalizing it, this is the right hypochondrium, left hypochondrium, then lumbar region, and then you have, these are the lumbar regions, iliac fossa inguinal region, hypogastrium, and that's the epigastrium, and that's umbilical region. So when you're looking at a lump here in the right hypochondrium, along with palpable liver, you suspect it to be a gallbladder lump. Now, naturally, it's a correct question to ask whether it was tender or not. It was non-tender. Patient gives the history of pain, abdomen, vomitings, no jaundice. They are important. Now, if there is no jaundice and there is a big gallbladder lump which is almost fixed. Now, why do we call it a gallbladder lump? A gallbladder lump has some characteristics. First of all, the site where it is located. We keep saying right hypochondrium, but please understand right hypochondrium is a very narrow space, and usually it will cross that zone and will get into the lumbar region or sometimes in the umbilical region. So, depending upon the size, of course, but rarely remains confined to the right hypochondrium. Secondly, it moves on respiration. And why does it move on respiration? Because it is attached to liver, which is attached to the diaphragm. So, the lumps that are attached to the diaphragm or to the lumps that are attached to diaphragm. So, they are attached to organs that are attached to diaphragm, they can still be moving. So, either it is directly attached to diaphragm or it is indirectly connected to diaphragm, it will move on respiration. So, therefore, that's the next finding that you look for. And thirdly, if it is a benign lump which is very fresh and just a distended gallbladder, there will be side to side mobility. However, the same cannot always be present. Suppose it's a malignancy, it will be fixed to the surrounding structures. It may not move, but classical gallbladder lump will move side to side. And you cannot get above the swelling, because you can feel, again drawing it, you can feel all the borders, this border, this border, this border, but you can't feel here. This is where the liver is. So, very often it is difficult to differentiate it from a nodule that is directly arising from the liver. So, the nodule that is directly arising from the liver can be confused with the gallbladder mass, and that is where you look for the consistency. And therefore, it is a good question that Naveen asked, what is the consistency like, what is the surface like? I mean, consistency of liver would be different from that of gallbladder, depending upon where the pathology is. In this case, the gallbladder was firmer, except in the region where it is bulging out. So, you can't really make out whether there is any bridging tissue between gallbladder and the liver. So, it will be almost like a nodule on the liver. So, one may be right in saying it is hepatomegaly with nodular surface. So, a metastatic liver. Hepatomegaly with a nodular surface is a metastatic liver. So, a lot of you have written hepatoma, hepatocarcinoma. That's usually involving the whole. The term hepatoma can be misleading, and you may think it is benign. Hepatocarcinoma is better, or hepatocellular carcinoma, where you have a preceding history of jaundice, or it is related to hepatitis. So, those features may be there, and usually both lobes are involved. And also the surface is smooth. Why should it be nodular? Because nodular means metastatic nodule. So, since it is a primary malignancy, its consistency is hard and surface is smooth, and you have preceding history of jaundice, which is important because you need to look for the reason. So, to sum it up, it is essentially a gallbladder mass, hard, and with hepatomegaly, which is although firm but had variable consistency. I won't say variegated. Why? Because there are only two consistencies that I can feel here: firm and hard. Surface irregular. So you're looking at a metastatic liver. So now the diagnosis looks easier. The problem at the in the gallbladder with so the problem is in the gallbladder and there are metastases to the liver. That's how you look at it. Now the lady is down. What are the questions you need to ask? Where does she reside? The carcinoma of the gallbladder is classically seen in the Gangetic plains. This is the area where there is a maximum density of people, and it has been linked to many chemicals in the river, and the incidence keeps increasing as you go downstream, and you have very high incidence in Banaras, Patna, Bihar, etc. As I said, it gets more and more polluted. That could be a factor. There are many factors. People have studied the factors relating to the kind of dietary habits of people in this area. Some people also say that there are just too many people here, so that's one reason. The density is maximum here. And thirdly, some people they have done their studies on the metals, heavy metals, and arsenic, nickel, lead in the water, etc. So one doesn't know if one particular factor is contributing. But thus the residence becomes important, therefore you must find out whether the patient is coming from an endemic zone of GB cancer. Even Delhi is an endemic zone, mind you. We are in the plains of Gangetic. Gangetic plains include Delhi also, but another reason why Delhi is a factor is because floating population from all these areas. There are a lot of people coming from northeast or eastern part of India living in Delhi. Second thing is you look for here, it may not be classical, but usually patient will give you history of cholelithiasis. That is, patient will have history of cholecystitis off and on. She is giving a history of pain abdomen off and on, but for the last 3 years, but not specific, although you should work harder at that. Do you know 90% of patients with carcinoma gallbladder have gallstones? And at the same time, they don't have squamous cell carcinoma. They have what is called as adenocarcinoma. So people link it to biofilm. We have our own publication on this. If you're interested, you can always follow it up on the PubMed, where we found that cholecystitis with biofilm of bacteria may be a factor. So this history is important. The other history that is important is jaundice is late. See, if it was a disease involving the liver, as some of you have written, the jaundice would be early. Jaundice is late in carcinoma gallbladder. Why? There are many theories, and I'll just touch a few. This is what is the biliary tree like, if I may draw it for understanding. And actually the most common cause of obstructive jaundice here is these nodes at the porta. But rarely there can be a direct infiltration by the gallbladder. If there is a cancer, it can grow this way, grow this way, grow this way. Or if the growth is proximal, it might happen. The commonest site of CAGB is fundus of the gallbladder. So it won't directly be involving. Therefore, jaundice is late. That's one reason. And the other reason is, so one is jaundice is late on account of the growth being at fundus. And the second, which is more important, is a retrograde lymphatic drainage from gallbladder. What is that supposed to mean? From here, they go, the lymphatics from carcinoma gallbladder go to the cystic gland of Lund, and then they traverse down to the celiac axis, then along the common hepatic artery they reach here, and finally this is involved. So this takes a little while. You can answer by simply saying that it is the retrograde spread along the lymphatics, and the cause is lymphatics mostly, as I mentioned in my initial description. And the other reason is the carcinoma itself grows or arises from fundus. Since the carcinoma arises from the fundus and there is a retrograde spread of lymphatic, jaundice is late. Now in this case, you still find the patient is not jaundiced, which is a point in favor. So we made a diagnosis of carcinoma gallbladder with metastasis to liver, although the CT scan is almost a takeaway. But before that, clinically, how do you make the diagnosis? What I was trying to describe to you. Now, so these are points in history, that is past history of pain. Wherever there is a stone, it cries. Remember that. So if there is stone, it will cause pain. So that can be associated. And number two, no jaundice. Then points on examination. They are easy to understand. Hard, globular, right hypochondrial mass, which is gallbladder, with irregular or nodular surface of liver. This is what leads to, this is what makes you think in terms of CAGB. Now, having said that, you can't swear by it. You need to investigate, and we do investigations to confirm. Is there any differential diagnosis? Since some of you mentioned hepatoma, I have already explained. There should be preceding history of jaundice, viral hepatitis related history. It involves both lobes usually. The liver is hard but smooth surface. It's not variable. And remember, it's not common. Then there is no history of pain usually. Biliary colic, as we call it, which you don't have here also classically, but I'll suspect it to be carcinoma gallbladder unless proven otherwise. So therefore, I'll then investigate. What do I do? Now, Naveen has asked about the color of stool, etc., etc., etc. Patient has no jaundice, so color of stool should be fine. The right hypochondrial mass, which is hard in consistency, with part of the liver which looks like hard and involved. To confirm the diagnosis, so investigations to confirm the diagnosis. Most of you have done very well in this. I must compliment you. To stage the disease, and then investigations to treat the patient. Never treat the disease, treat the patient. To confirm the diagnosis, of course, we will do an ultrasound which doesn't confirm, but is an extension of clinical examination, inexpensive, non-invasive. Everything good about it. So what do you want to see? You can at least see the organ of origin, which is very beneficial. If you know the organ of origin, you'll know whether it's gallbladder. And do you know, for stones, it's the most sensitive, amongst the most sensitive tool, ultrasound. So you'll rule that out. You'll know whether there is a growth in the gallbladder. You will see the IHBRs and EHBRs, both internal and external, intra and extra biliary radicals. And actually you will be able to see the lymph nodes. So most of the time you will be able to see most of these features. Once you find that it is suspicious of carcinoma gallbladder, you can do an investigation to confirm. We don't poke in a needle. Why don't I do FNAC after this? I have seen a carcinoma of the gallbladder on ultrasound. I should simply put in a needle, get a diagnosis and treat it. But we don't do that. Why don't we do FNAC? Because you can upstage the disease. How do I upstage the disease? By connecting it to peritoneum. I am going through the peritoneum, so it can be a problem. This is the abdomen, that's the gallbladder. I go through the abdominal wall, and when I come out, I am actually I can make it into a metastatic disease. So therefore, we call it upstaging the disease. It becomes metastatic. So we do a CT. The same is true for pancreatic cancers, gallbladder cancers. Don't put in a needle. It's not supposed to be done. So FNAC can make a resectable one into unresectable one. That is what FNAC can do. So avoid FNAC in these patients. If it is resectable, we don't do an FNAC. When do we do an FNAC? This I'll answer here. So when it is already not resectable. That is, there is ascites, the liver is studded with metastasis. You're not going to operate anyway, so resectability is already known. So FNAC won't change it. Then you have peritoneal deposits, etc. In this scenario, we need a diagnosis so that we can put some alternative treatment like chemotherapy. So we generally don't do it. So we come down to CT. CT. And CT picture, if you saw, it classically shows the gallbladder with infiltration into liver. At the same time, you don't see any element of ascites, peritoneal mets. Now, is it resectable? Well, resection means you should be able to get an R0 resection, which means microscopic freedom from cancer. It is likely if you have liver which you can resect, say in this case the liver was involved, and if I can remove the whole thing and get a clear margin, I should take it as resectable. But if there are metastases to the peritoneum or there is ascites, we know it's not resectable anyway, so you should not even attempt resecting. In that case, the patient goes for chemotherapy. So what would be a contraindication to resection? Multiple bilateral, both lobes of liver involved. Up to one lobe you can resect. But mind you, gallbladder cancer is a surgical disease. So we don't have a choice, and it is one of the bad cancers which kills in less than a year and two. So should we forget the standard teaching, primum non nocere, which means above all, do no harm. So if there is no harm, you can resort to it. Otherwise, we don't operate on such patients. They can be treated by other modalities. So it is resectable as long as there is no jaundice. Why am I saying jaundice? I've already explained that jaundice here is usually due to porta nodes, not. So if it is just the infiltration into the common bile duct, you can resect it still. What surgery is done, I'll just tell you. But if the porta nodes are involved, which will cause jaundice, usually that's the cause of jaundice, then probably you will not get a clear margin. You can't do that. So jaundice is an absolute, almost an absolute contraindication. Besides that, of course, ascites, peritoneal mets, and distant mets. You can't do that surgery. Suppose it's a resectable cancer, what surgery is offered? It is resectable. So what do? I do what is called as a radical cholecystectomy. What is radical cholecystectomy? That's liver, both lobes. That's the gallbladder. Right. That's gallbladder. So we remove and block the lymph nodes which are peridocal along with the gallbladder, along with a cuff of the liver. A cuff of the liver which gives you a clear margin. So you may have to go wide here. And of course, as I mentioned, these nodes are removed. Some people like to remove the common hepatic duct, biliary duct also with it. So common hepatic duct is where they then anastomose it. But most of us would like to remove the retropancreatico-duodenal nodes along with peridocal nodes, along with nodes around porta hepatis, along with gallbladder, along with a cuff of the liver with a clear margin. That is called radical cholecystectomy. Right? So that is basically, if I put it the other way around, gallbladder plus, usually people talk about segment 4 and 5, but that's not how we do it these days. We get a cuff of liver with clear margin, what is also called as R0 margin. So gallbladder plus cuff of liver plus peridocal pancreatico-duodenal lymph nodes. The whole thing is called radical cholecystectomy. If you cannot do it for whatever reason, then it's not much better not to operate, because an incompletely done job is worse than no job done. That's radical cholecystectomy which you offer. Now, how can you palliate such patients? What are you expecting? If you go back to the picture or the CT, you find that liver is quite extensively involved. There are nodes at the porta also. So what is going to sooner or later going to happen? Patient will develop jaundice. And the duodenum comes very close to gallbladder. What you are going to get is also involvement of the gastric outlet, but that's not very good because the patient doesn't live that long. So we do palliative, prophylactic, biliary decompression using stents. But the disease has got a very poor outcome. Some people recommend putting the patient on neoadjuvant chemotherapy, which is cisplatin based, but not a standard of care. Important to remember terms like radical cholecystectomy, no FNAC, resectable versus non-resectable, which I've already covered, and finally the palliation. They don't have any, usually the jaundice is late, and jaundice is late. Thank you.